Hello, my name is Faz Pakarian. I am a consultant gynecologist with over 25 years experience. I practice in the NHS and at two private hospitals, the Montefiore Hospital in Hove and Goring Hall Hospital in Goring. Today, I'd like to talk to you about prolapse and incontinence. Incontinence is a debilitating disorder which affects many patients. It affects women and men, but today, obviously, I'll be talking about its implication on women. Incontinence can be divided into the overactive bladder incontinence or stress urinary incontinence. Overactive bladder symptoms include urgency, frequency, and getting up at night, specifically to pass urine. Approximately 1 in 6 women suffer from the overactive bladder symptoms, and as mentioned earlier, it is a debilitating disorder. The treatment for the overactive bladder is straightforward. It is often by the way of physiotherapy and tablets. If these simple measures do not work, the other options include injection of Botox or neuromodulation. I work very closely with physiotherapists, both at Goring Hall Hospital and the Montefiore Hospital. In my opinion, physio plays a very important role in management of patients with the overactive bladder symptoms. The other problem with incontinence is the stress urinary incontinence, where there is involuntary leakage of urine when the pressure inside the bladder exceeds that of the urethra. For example, this may happen whilst running, exercising, coughing, sneezing, jumping on the trampoline, or sometimes even walking. Once a detailed history is taken, followed by an examination, I tend to carry out a scan to ensure there are no abnormalities of the bladder or something pressing down on the bladder, like a big fibre or an ovarian cyst. Once that's the case, I usually carry out urodynamic studies, and based on those results, offer patients surgery. Surgery involves either injecting Bulkamid into the bladder neck, fascial sling, or a Colposcopist suspension. Whilst Bulkamid is a least invasive procedure that can be carried out under local anesthetic, it carries the least success rate. Fascial sling is a very successful operation with up to 85-90% of patients becoming dry. Colposcopist suspension is another important operation with good success rate. These types of operations will be discussed in detail following the discussions in the clinic. If you would like to discuss issues with incontinence, please contact my secretary, Emily Cully, on 07889 460 924. I will also briefly talk about management of prolapse. Prolapse is also a very common condition, and it can cause debilitating symptoms for patients. Management of prolapse includes physiotherapy, using pessaries for support, or surgery. In my opinion, physiotherapy is once again important, but if the prolapse is excessive, then the options are either using a pessary or surgery. I attend regular multidisciplinary meetings where I meet physiotherapists and other urogynecologists to discuss incontinence and vaginal prolapse. I think these two conditions should be managed by consultants who have been trained in urogynecology and not by others that carry out one procedure once every few months.